This is SG2 Perspectives, a conversation with industry experts and SG2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
Welcome to SG2 Perspectives. I am your host, Kelly Richard, and today I will be interviewing our frequent host, Trevor DaRin, along with SG2 fellow Valinda Rutledge about Medicare Advantage. The question we're going to answer today is, I can see MA is growing in my market, and I hear about changes to the MA program nationally. So what? How will the growth of MA affect health system strategy? And Valinda, you're sort of a resident DC insider, going to meetings every day on the Hill. Given our new reality, where are you now? Are you meeting with politicians or are you at home with your dogs?
I am not meeting with politicians, but I am home with my dog. So hopefully I've put the dog upstairs so you won't hear her barking. Right now, how work is being done is in DC is by emailing and telephone call. Thank heavens I have everybody's email and their cell phone number. That's been very helpful.
All right, let's dig in. So we're starting to see early 2020 Medicare enrollment numbers, and MA continues its steady growth. More people who are Medicare eligible are choosing MA each year, and of course, the Medicare eligible population is growing fast. Why is MA continuing to grow?
Well, first of all, both the administration and Congress likes MA. They like MA because there's a predictability in terms of the cost. As you know, they set the benchmarks and then the plans bid. And so they have a sense of what that cost is going to be for the next year. Versus Medicare fee-for-service, they have no idea. They can estimate what the cost will be for the federal government. So having people enter into MA allows the federal government to sort of have a predicted budget. The other thing that's making MA attractive to enrollees is the last few years they have allowed a lot more flexibility in MA, and that started with the Bipartisan Budget Act of 2018. It has allowed MA plans to have different and enhanced supplemental benefits. Previously, the supplemental benefits were dental and vision, and you had to offer it to the entire population. With the Bipartisan Budget Act of 2018, they have allowed supplemental benefits for just different segments of the population. So we're beginning to see things like delivering groceries and transport. And also what we're beginning to see is almost 50% of the MA plans have a zero premium. So it's not only MA grows because the administration, Congress loves it because of the predictability in the federal budget, and the enrollees love it because of the additional supplemental benefits and zero premiums.
Right. There's a supply side story, which is government loving it, and there's a demand side story, which is, face it, unlike commercial insurance, MA is mostly an individual choice. Yes, 25% of enrollees are coming through group plans, but that still means the overwhelming majority are an individual choice. And in 2020, 80% of new enrollees were in plans with $0 premiums. That's huge. That's showing that consumers are getting more accustomed to being price sensitive to kind of their total healthcare spend as they're aging into Medicare from commercial products where they probably increasingly have high deductible plans. And so that price sensitivity is carrying over, and it's making that $0 premium kind of an easy bait to attract enrollees. At the same time, those same trends on the commercial side in narrow networks are carrying over to MA, where consumers are just more comfortable with narrower network HMO products. And so moving into Medicare, that traditional balance had been, do I want MA that has a narrower network, or do I want traditional Medicare where, yes, I may have to pay premiums, but I'm going to get to go to any doctor I want? And that trade-off's actually tipping in favor of MA, not only because so many more enrollees are moving into zero monthly premium plans, but HMOs are still the majority of MA enrollees, about 65%. But even that's not an overwhelming majority. And PPO products in 2020 grew faster than HMO products. So we're kind of seeing that historical trade-off may not be the exact same going forward. And then kind of the final thing, I don't know if this is demand or supply side, but payers make a lot of money in MA. And all the big publicly traded players, Humana, United, Aetna, Cigna point to MA as a huge growth engine. And in 2020, they captured most of that new growth. United grew by 218,000 new enrollees. And trend to watch here, 150,000 of those were in PPO products. So keep an eye on that. Humana was actually the biggest grower, over 250,000 new ones. And Aetna, 185,000 new enrollees. Don't sleep on that. I don't know if that's around a connection from CVS, but that's faster than they've grown in the past, especially compared to the other.
Let me push the two of you on that one a little bit, because costs continue to go up for Medicare and payers are profiting heavily on this. Why aren't MA benchmarks going down? Why is it still continuing to be so profitable when costs are just so high for the government? Why don't they cut these costs down a little bit more and reap a little bit more of the savings for themselves?
So from a legislative point of view, the benchmarks are tied, and this is in legislation. So any changes in this would have to be made at the congressional level. But the benchmarks in which the plans bid are tied to fee-for-service cost in each of the counties. So you've got the benchmarks for an MA is tied to a fee-for-service cost, and the fee-for-service population is uncoordinated. They can go wherever they want. They can access as much services as they want, where MA, as you know, are much tightly coordinated. If in some plans, if you go outside the network, you're not going to be reimbursed. So number one, those MA benchmarks are tied to fee-for-service costs. And so you've got a tightly coordinated network that suddenly is tied to a fee-for-service cost. So you're going to get a lot of savings in that. Number two is then they're allowed to do risk adjustment beyond those benchmarks. So there's a lot of money made. To me, it's almost apples to oranges versus the benchmarks being tied to MA. And of course, any conversation in which people talk about potentially changing those benchmarks from not being tied to fee-for-service, but being tied to MA cost in those areas, you can imagine the plans are very, very aggressive in terms of lobbying the federal government, congressional leaders to avoid that. And then second, then they add a risk adjustment on top of that. So the combination of both of that does make the plans see MA as very, very profitable. Now, we are starting to see some slight movement, and the movement is because fee-for-service costs are slightly going down because we are seeing more ACOs and alternative payment models like bundles in the fee-for-service population. So we're starting to see that starting to go down a little bit with that. The second thing that does cap a little bit of the cost is in the Affordable Care Act, there is a section in which the counties are capped. And so 48% of the counties are now capped. And so even if a plan gets a 5-star rating and should be getting reimbursement above even the benchmark, they can't. So we're starting to see more and more of the counties being capped because the cap of the benchmarks are set with the Affordable Care Act. So we're starting to see some movement in a downward projection. However, recognize again, those benchmarks are tied to a totally uncoordinated population.
Leaving Florida out of the equation because, I don't know, Florida's kind of another country. But in most places where MA is big, you start to see the changes in utilization patterns that physicians start to practice because the MA population gets over a critical mass. And they're getting a lot of communication and incentive programs and quality programs from MA payers. It starts to impact the fee-for-service population too, because physicians can't care for everyone differently. In many places where MA is big and growing, you see some of those utilization numbers also driven down for traditional Medicare, just by the presence of MA growing.
So do you think this growth trend will continue given all of these different dynamics?
I really don't have much evidence that it won't. And I think big picture, even as you said, Valinda, there's behind the scenes lobbying battles that are fierce. But big picture, MA payers can still stand up and say, we can do it cheaper. And there's a promise of decreased cost that so far is mostly captured by the payers. Some of it trickles down through incentives to providers and provider systems. But when their monthly and therefore annual costs are 25% less, that's a big number that, sure, we know it's going to happen administrative or legislatively to try and change some of the mechanisms through which the payers get paid so that either taxpayers or individuals, I mean, they already have $0 premiums, but how else can some of that value trickle down to consumers? That'll be the big question. And something you mentioned earlier, Valinda, around the growth of supplemental benefits. This is something I really expected was going to be a bigger driver of new enrollees moving into MA. 2019 was the first year that supplemental benefits can be involved, and plans didn't have a lot of time to prepare because the announcement was made in the spring when they were already pretty far down the road of their 2019 products. So 2020, they had a full year. We expected a lot. There was a lot more plans. I think we moved from something like 170 plans in 2019 that had supplemental benefits to 500 that had supplemental benefits in 2020. But you know what? The plans that consumers picked had pretty traditional benefits. It was eyewear, it was gym memberships, it was dental coverage. It wasn't what I had hoped, and maybe some of us expected, was going to be consumers really prioritizing some of the big, new, cool, different supplemental benefits like transportation, like home modifications for safety, like meal delivery, like caregiver support, mostly growth in pretty bread and butter supplemental benefits that have been around a long time. But still, they're attractive to consumers. And so, yeah, I think MA is going to keep growing. What do you think, Valinda?
Absolutely. And I think the other thing that is happening is CMS is expanding the pool of those that are eligible to enroll. In fact, January 1st, 2021, anyone that is end-stage renal disease can move from the end-stage renal disease benefit coverage at Medicare to MA. In the past, if they were in an MA plan and they develop end-stage renal disease, they could stay in it. Now they can actually move from an end-stage renal disease benefit plan to actually MA. And we're certainly going to get some movement of patients into that. Now, I will tell you the plans are somewhat concerned and worried about the movement of end-stage renal disease patients from end-stage renal disease benefit a category to MA because they're concerned whether the development of that benchmark is going to be at the state level rather than county. It can't be more than 100% of Medicare fee-for-service. And what they're concerned about is the in-center dialysis centers that for the most part are owned by just a few large corporations in this country have already indicated to MA plans that they're not going to negotiate at 100% of Medicare fee-for-service. So the plans are concerned that from Medicare, they're going to get this benchmark for this end-stage renal disease population at 100% of Medicare fee-for-service. But these in-center dialysis centers are saying, we're not going to give you that rate. They have to take that rate for Medicare. So the plans are concerned about if that part of the care in terms of being able to have any cost savings can't be done, then to be able to have any kind of profitability or at least break even on this population, you're going to have to find care redesign opportunities in a non-in-center dialysis. And that's the bulk of the cost of that. So they are a little concerned about the addition of that population, and we'll have to see how that rolls out. Of course, moving them out of in-center hemodialysis into home dialysis or home peritoneal dialysis is probably the answer, but you need nephrologists to certainly support that movement. And we have not seen that traditionally happening in this country.
Great. So the story that I'm really hearing here is one that involves the payers and the beneficiaries and maybe, some of these large dialysis centers in the ESRD case. But where do the health systems fit into this equation?
As you know, Kelly, I was 15 years as a health system CEO. So I know and am very familiar with the challenges that happen at a health system level. And I will tell you, I highly recommend health systems look at developing contracts with the MA plans, risk-based contracts with the MA plans. And why they need to do this is there's a lot they can learn in terms of developing risk-based contracts with the MA plans to manage the MA population. First of all, it's a more predictable benchmark than the benchmark that you have in ACO. So that helps you be able to understand how to take a benchmark, model it, and go out, do some of the modifications on it. The current ACO benchmarks are a little unpredictable. We're recognizing that there's a degree of randomness in it that people have not been able to take out of that. I think in the future, CMS will look for that. But right now, the MA benchmark is much more predictable. Second, you have alignment of beneficiaries. The beneficiaries know when they sign up for this, they're going to stay with the network. So you can do some of those really exciting beneficiaries engagement and see the difference it makes. The third is telehealth. Telehealth in MA is very broad. So a lot of people that have been doing risk-based contracts in MA, they started telehealth January 1st, 2020, a broadness expansion of it. So many of those health systems and practices had telehealth all up and running infrastructure. And so now with the crisis that we have with the coronavirus and allowing the expansion of telehealth in Medicare fee-for-service, those health systems are one step in front because they've already had that infrastructure set up. They were doing it with the MA population. So the MA rules allow a lot more flexibility, a lot more testing, new models of providing care than the Medicare fee-for-service. And finally, the fourth is risk adjustment. I find that health systems that have risk-based contracts with MA plans understand risk adjustment much better. They're the whole within the practice as well as within the health system, they better understand how to capture those comorbidities much better than if you were just in an ACO type of arrangement with Medicare fee-for-service.
Yeah, and your experience is so invaluable here, Valinda. One thing that I encourage health systems to do is don't be satisfied getting a couple percent above fee-for-service Medicare from the MA plans. It might seem okay today. It might seem like the least of the many challenges around payer mix shift, but that kind of slow drip of movement from traditional to Medicare Advantage and the utilization changes that will come with that, it's not something that flips overnight. And so kind of slowly, progressively, you may notice the change. One thing to look at to see how much MA is impacting you is look at length of stay shift for your MA patients. Once MA really takes hold, many payers would rather use that DRG payment to the hospital, keep patients inpatient a little longer instead of discharging them to SNF. We see SNF utilization actually the biggest area that MA payers really drive down utilization, but you can kind of see those upstream impacts. So it's little pieces like that that really make the value proposition Valinda talked about around starting the multi-year conversation with payers in your market to talk about taking on some risk, starting with shared savings and moving into or having a vision for moving towards eventually capitation.
Great. And what do we recommend health system leaders do to be successful in MA today, as well as to just plan for the future?
Yeah, I'll say a couple of things, but I'm sure Valinda has more to add here. Really, one of the pieces of feedback I've heard is if you're not in a market where the payers have traditionally been giving risk and doing shared savings contracts, it can be tough to get that conversation started. I've seen some health systems get kind of impatient because they see this shift happening around them. They want more control. And so I've actually seen the most common response be, let's talk about either a co-branded or our own provider-sponsored health plan. And that's a totally different set of skills and services. Yeah, there are a lot of partner organizations out there that can help you manage the risk, do the administrative work. But I've also seen some of the actuarial projections for the first few years of these plans, and they're ambitious. And having tracked the growth of many of these over those same timelines, they're really not keeping up with those projections. Some of the fastest growing provider sponsored plans this year, like Henry Ford Health Plan, not new, been around a long time. They only picked up 5,000 new enrollees. And many of the smaller co-branded plans picked up 1,000 or 2,000 new enrollees. That's a long journey and a long road to get to a viable population level. A word of caution there that get the conversation started around moving to shared savings, but the provider sponsored plan option is there and there are partners to help.
Sure. And Trevor, really quickly, it doesn't take as many beneficiaries to take on risk in MA than it does in other populations. Is that correct?
Yeah, I've heard the numbers 10 to 15,000. You'll be okay in MA managing that population. It's not 50 to 100,000 target that maybe we heard about 5 or more years ago when we were thinking about ACOs and population health. But if you're only picking up 1 or 2,000 new enrollees a year, is your board going to be happy with 7 to 8 years of growth here until you get to viability? That requires a lot of patience.
Absolutely. Valinda, one last question for you. What changes to regulation and policy should we be focused on in MA in paying attention to going forward?
Yeah, so first of all, understand that the Learning in Action Network, that's a private-public partnership between HHS and many of the stakeholders in our industry, such as health systems and health plans and states. They have actually put together a goal to have 100% within 5 years of the MA contracts being a level 3B or a level 4. And those are level 3B and level 4 are risk-based contracts. So they would like to actually move the MA product to much more of a risk-based contract between providers and the plans. We understand that when those partnerships happen, that's when we see tremendous care advantages happening. We see increase in quality. So we're beginning to see a push going forward on that. There is a non-interference clause which prevents Congress by passing legislation mandating these kind of changes in the MA plans, but they're certainly strongly encouraging it. We're starting to see, as I said, end-stage renal disease patients coming into it, being allowed to enroll in MA. We're also, the CMMI is testing having hospice benefit actually being added to the MA plan. So we're starting to see much more flexibility in terms of supplemental benefits. And right now, to address social determinants of health, you can only do that through an MA plan by what's called special supplemental benefits for the chronically ill. And you have to meet a chronically ill definition to be able to have supplemental benefits that are focused on social determinants of health, non-health related, like transport to things other than the doctor, like to the grocery store or giving groceries, those kind of things. So it's been somewhat narrow. I think we'll see that much expand over the next few years. And it wouldn't surprise me if they actually dropped the chronically ill and just focused on you being able to make that determination that someone meets a criteria and you put the criteria down that you want to use that benefit for. So contracts, risk-based contracts, we're going to see more of those. A second is expansion of benefits like in supplemental benefits or hospice. And third, expansion in populations like end-stage renal disease. Both Congress and the administration, and it's bipartisan, which is not a lot of times we see that anymore, but it's a bipartisan support in these changes.
Wonderful. Well, I think we can expect to see the continued growth of Medicare Advantage. And here at SG2, we're pretty bullish on that prediction. I want to thank Valinda and Trevor for coming on the podcast today. This has been another episode of SG2 Perspectives. Thanks so much.
Valinda, thanks so much. You're the best.
Thank you.
If you like what you're hearing, please also listen and subscribe to our colleague, Dr. Tom Villanueva's Modern Practice podcast on Vizient's Medical Leadership channel. Tom discusses key healthcare trends through the clinical leadership lens. You can find it wherever you listen to podcasts. Thank you for listening and stay healthy.
This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you.